Hey guys, tonight we're talking about grey death, a substance so lethal that first responders were told not to touch it with bare hands, not to lean over it, and in some cases not to even breathe near it. That's not a metaphor, that's a literal instruction issued by law enforcement agencies in the United States starting in 2017. For context, heroin, the drug that defined a generation of addiction and grief, requires roughly 30 milligrams to kill an average person. Fentanyl, the drug that replaced heroin in the American drug supply and triggered a national emergency, requires about 2 milligrams. Grey death, depending on the batch, can kill at doses measured not in milligrams but in micrograms. That's 1/1,000,000th of a gram, a few grains, less than what clings to a fingertip. The paradox that makes this whole story so deeply uncomfortable is this. Every drug in grey death was originally created by scientists who were trying to stop suffering. Every single one. And somehow, working together in a plastic bag mixed by someone with no chemistry degree, they became one of the most efficient killing agents ever to hit a public street. Before we continue, subscribe to the channel if you enjoy these stories. Write in the comments where you're watching from and what time it is. I always find it fascinating to see people from around the world united by one story. To understand grey death, you first need to understand what opioids actually are and why humanity has been chasing them for thousands of years. The story doesn't start in a laboratory. It starts in a poppy field somewhere in the ancient Middle East, around 3400 BCE. The Sumerians called the poppy plant Hul-Gil, the joy plant. They weren't wrong about the joy part, they just didn't live long enough to see what came next. Opium, the raw resin scraped from poppy seed pods, was traded across the ancient world the way oil is traded today. Empires moved it. Wars were fought over it. Physicians prescribed it. Poets wrote about it. For most of human history, it was the only reliable painkiller that actually worked, which made it both a miracle and a trap. By the time the 19th century arrived, the Western medical establishment had begun tinkering with opium's chemistry, convinced that if they could isolate the active molecules, they could keep the pain-killing effect and strip out the addiction. In 1804, a German chemist named Friedrich Serturner isolated morphine from opium. He tested it on himself, as scientists cheerfully did back then, and reported that it worked magnificently. Within decades, morphine was everywhere, in patent medicines, in military field kits, in children's cough syrups. The addiction that followed was catastrophic, and widespread enough that 19th century America had a serious morphine problem long before anyone started worrying about heroin. Here is where the logic of pharmaceutical escalation begins, and it never stops. In 1898, Bayer, the same company that makes aspirin, synthesized diacetyl morphine and marketed it under a brand name. That brand name was heroin. Bayer advertised it as a non-addictive substitute for morphine. The tagline, in effect, was, "Tired of being addicted to the last thing we sold you? Try this." It was stronger, faster acting, and crossed the blood-brain barrier more efficiently than morphine. It was also, as the following decades proved, considerably more addictive. The solution had become the next problem. This pattern, a stronger drug introduced to solve the addiction caused by a weaker drug, would repeat itself with mechanical regularity for the next century. And each iteration, the drugs got more potent, more synthetic, more disconnected from the original poppy plant, and more difficult for the human body to survive. By the mid-20th century, the pharmaceutical industry had moved well beyond plant-based chemistry. Researchers were designing opioids from scratch, molecules that had never existed in nature, engineered specifically to bind to the brain's opioid receptors with maximum efficiency. The logic was still medical. Surgeons needed better anesthetics. Cancer patients needed pain management that didn't require constantly escalating doses of morphine. The goal was a drug that was powerful enough to handle extreme pain, but controllable enough to use in a clinical setting. In 1960, a Belgian pharmacologist named Paul Janssen synthesized a new molecule in his private research laboratory. Janssen was, by any measure, one of the most productive drug designers in history. His company eventually developed over 80 pharmaceutical compounds. The molecule he created in 1960 was called fentanyl. It was approximately 100 times more potent than morphine, meaning it achieved the same pain-killing effect at 1/100th of the dose. In surgery, this was revolutionary. Small amounts could be precisely dosed, the effect came on fast, and it cleared the body relatively quickly. For the operating room, fentanyl was an elegant solution to a genuine problem. Janssen was not trying to create a street drug. He was trying to help people survive surgery. This point matters because the story of Grey Death is full of scientists who were trying to help and succeeded, right up until their successes escaped the lab. Fentanyl entered clinical use in the 1960s and remained largely confined to hospitals for the next 2 decades. It was a professional's tool, used under controlled conditions by anesthesiologists who understood its risks. The general public barely knew it existed. Then, in the 1990s, something changed. The pharmaceutical industry, specifically Purdue Pharma, launched a campaign to transform opioid prescribing culture in America. The story of OxyContin and the Sackler family has been told extensively elsewhere, and it deserves its own deep dive. For now, what matters is the outcome. By the early 2000s, opioid prescriptions in the United States had skyrocketed, millions of people had developed physical dependence, and when prescriptions were tightened and pills became harder to get, those people needed an alternative. Heroin filled that gap first, then fentanyl filled it better. The specific mechanism by which fentanyl hijacks the brain is worth understanding because it explains everything that comes later. The human brain has a system of receptors, the opioid receptors, that respond to natural chemicals the body produces, called endorphins. These receptors regulate pain, reward, and breathing. They evolved to respond to the body's own signals, not to a synthetic molecule designed in a laboratory to hit them with maximum force. When fentanyl enters the bloodstream, it binds to these receptors with an affinity that endorphins can't match. The result is a wave of pain, relief, and euphoria, followed by something more dangerous: respiratory depression. The brain, flooded with the signal to relax, tells the lungs to slow down. At low doses, this is manageable. At higher doses, breathing slows to the point where it stops. This is what an opioid overdose looks like. Not convulsions, not dramatic collapse, just a quiet, gradual cessation of breathing while the person appears to be asleep. Fentanyl's potency made this window between a useful dose and a deadly dose extremely narrow. In a hospital, that narrow window was managed by trained professionals with monitoring equipment. On the street, it was managed by nobody. And by 2013, fentanyl was on the street in quantities that nobody had anticipated. The journey from Paul Janssen's laboratory in 1960 to a street-level drug crisis in 2013 took 5 decades and required the failure of multiple systems simultaneously: regulatory, medical, law enforcement, and social. No single villain drove it. No single decision caused it. It was the accumulated weight of pharmaceutical ambition, corporate greed, desperate patients, overwhelmed doctors, and a drug enforcement framework that was always reacting rather than anticipating. What made fentanyl different from every previous drug crisis was its efficiency. Heroin was bulky by comparison. You needed relatively large quantities to produce a meaningful supply for dealers. Fentanyl was so potent that an amount small enough to fit in a standard envelope could represent thousands of doses. This made it easy to ship internationally, difficult to detect, and extraordinarily profitable. Chinese chemical manufacturers, operating in a grey area of their country's pharmaceutical regulations, began synthesizing fentanyl analogues, molecules slightly different from the original but with similar or greater potency, and shipping them directly to American buyers through the postal system. The DEA watched the overdose numbers climb and struggled to understand the scale of what was happening. Toxicology labs that had never needed to test for fentanyl were suddenly being asked to identify it in overdose victims, and many of them weren't equipped to do so. People were dying of overdoses that looked like heroin deaths, being recorded as heroin deaths, while the actual cause sat invisible in the toxicology report. By 2016, fentanyl had not just entered the American drug supply, it had taken it over. In many parts of the country, what was sold as heroin was actually fentanyl mixed with cutting agents. Users who believed they had a tolerance built up over years of heroin use discovered, fatally, that fentanyl tolerance was an entirely different calculation. The death toll climbed past 20,000 annually in the United States from synthetic opioids alone. Public health officials called it a crisis. Politicians held hearings. Naloxone, the overdose reversal drug, was distributed in communities across the country. And then, just as the infrastructure for responding to fentanyl began to take shape, the chemists produced something worse. The machinery of pharmaceutical escalation that had turned morphine into heroin and heroin into fentanyl was still running. It had never stopped. It was simply operating now not in legitimate laboratories, but in illicit ones, driven not by the desire to reduce suffering but by the cold logic of the drug market, and by the terrible momentum of a system that had been building toward this moment for 60 years. Grey Death wasn't an accident. It was the next step. The transition from heroin to fentanyl in the American drug supply didn't happen with a press release or a public announcement. It happened quietly, death by death, in apartments and alleyways and gas station bathrooms, while the people responsible were thousands of miles away, and the people dying had no idea what they were actually taking. To understand how fentanyl conquered the street market so completely, it helps to understand the basic economics of the heroin trade. Heroin is a bulky product. It starts as raw opium harvested from poppy fields in Afghanistan or Mexico, gets processed through multiple stages, crosses international borders, passes through layers of distributors, and arrives at street level as a powder or a tar that still carries the weight and smell and physical presence of its agricultural origin. Moving heroin is logistically expensive. Dogs can smell it. Customs agents know what it looks like. The profit margins, while substantial, are constrained by the physical realities of the product. Fentanyl dissolved those constraints almost completely. A kilogram of pure fentanyl, worth a few $1,000s from a Chinese manufacturer, could be diluted into enough street product to represent millions of dollars in retail value. The entire kilogram fit in a small flat-rate shipping box. It had no distinctive smell. It looked like any other white powder. Standard drug detection equipment wasn't calibrated for it in the early years, which meant it passed through mail sorting facilities and customs checkpoints with a success rate that would have been unimaginable for heroin. Chinese pharmaceutical and chemical companies, not shadowy criminal enterprises but registered businesses operating in legal grey zones, had been producing fentanyl analogues since at least 2010. China's regulatory framework for novel psychoactive substances was, at the time, years behind its manufacturing capacity. Chemists working in legitimate-looking facilities synthesized molecule after molecule, each one slightly different from the last, each one technically legal under Chinese law, until regulators caught up and banned it specifically. By the time one analogue was scheduled, 3 more had been developed and were already in transit. The supply chain was elegant in its simplicity. A buyer in the United States, sometimes a dealer, sometimes an intermediary, placed an order through a darknet marketplace, or, in many documented cases, through a straightforwardly professional-looking website. Payment went through cryptocurrency. The package arrived by mail, often labelled as something innocuous, within 1 to 2 weeks. No middlemen in multiple countries, no mules crossing borders with product hidden in luggage, just a small package moving through the legitimate postal system, indistinguishable from the hundreds of millions of packages shipped internationally every year. By 2013, the CDC had begun noticing something unusual in overdose data from states like Ohio, Maryland, and Massachusetts. Synthetic opioid deaths were climbing sharply, not the prescription pill overdoses that had dominated the previous decade, but something different. The toxicology profiles didn't match heroin, they matched fentanyl. The problem was these weren't patients who'd been prescribed fentanyl. Many of them had no history of prescription opioid use at all. They were heroin users who had unknowingly purchased fentanyl, or a mixture of heroin and fentanyl from dealers who were themselves sometimes unaware of exactly what they were selling. This last point is critical and often overlooked. The fentanyl crisis was not primarily driven by dealers deliberately poisoning their customers. It was driven by a supply chain so fragmented and so far removed from any quality control that dangerous mixing happened almost by default. A dealer buying what was described as heroin from a wholesale supplier had no way of knowing what percentage of the product was actually fentanyl unless they tested it themselves, and most didn't, because testing took time, cost money, and wasn't something the industry had historically required. The result was product of wildly inconsistent potency, distributed to users whose tolerance had been calibrated to heroin, not to something 100 times stronger. The difference in lethal dose meant that the margin for error was essentially zero. A user who measured out what had always been a safe amount of heroin and found themselves with a product that was 30% fentanyl instead of 10% was not making a reckless choice. They were making a reasonable calculation based on wrong information. The wrongness killed them before they had time to understand what had happened. Ohio became one of the clearest early examples of how fast fentanyl could reshape a local drug market. In 2013, the state recorded 84 fentanyl-related deaths. By 2016, that number had climbed past 2,000. The increase wasn't driven by a sudden surge in new drug users. The population of people using opioids hadn't doubled, let alone grown by 25 times. What had changed was the supply. Heroin was increasingly being replaced by or adulterated with fentanyl, and the people using it had no reliable way to know. Coroners in smaller Ohio counties were overwhelmed. Some counties had to rent refrigerated trucks because the morgue capacity was insufficient. Law enforcement responded with the tools available to it: raids, arrests, seizures. But fentanyl's supply chain made traditional enforcement strategies nearly useless. Arresting a street-level dealer didn't interrupt supply, because the dealer's supplier was a website, and the website's inventory was in a warehouse in Wuhan. Seizing a shipment at a mail facility was a minor inconvenience to suppliers who were shipping thousands of packages a month. The DEA emergency scheduled several fentanyl analogues, making their sale and possession federally illegal. Manufacturers in China changed a molecule and listed a new product the following week. The cartels were watching all of this carefully. Mexican drug trafficking organizations, specifically the Sinaloa cartel and the Jalisco New Generation cartel, had spent decades building the infrastructure for moving heroin across the US-Mexico border. They understood distribution in a way that Chinese manufacturers did not. What they lacked was a domestic synthesis capacity for synthetic opioids. by approximately 2015, they had begun acquiring precursor chemicals and developing fentanyl production capability inside Mexico. They didn't need to compete with Chinese manufacturers for the wholesale market. They needed to integrate fentanyl production into their existing distribution networks and bring the entire supply chain under cartel control. The implications of this shift were significant. Chinese manufacturers sold to anyone with a cryptocurrency wallet and a mailing address. Cartels were selective, structured, and territorial. Once cartel-produced fentanyl entered the market, it came with the distribution efficiency that had made Mexican heroin the dominant product for decades, but in a form so concentrated that the same smuggling routes that had moved kilograms of heroin were now moving enough fentanyl to supply entire regions. Pressed pills became the next evolution. Rather than selling powder that users had to measure themselves, suppliers began pressing fentanyl into counterfeit pills, tablets designed to look exactly like pharmaceutical oxycodone, Xanax, or Adderall. The visual fidelity was remarkable. Pill presses available online produced tablets with the correct color, size, shape, and imprint to pass casual inspection. A person who bought what they believed was a pharmaceutical painkiller from a friend or a low-level dealer was actually consuming an illicitly manufactured tablet with no quality control, no consistent dosing, and fentanyl as the active ingredient. The DEA eventually found that in some seizure batches, more than 4 out of every 5 counterfeit pills contained a potentially lethal dose of fentanyl. Through all of this, the rising death toll, the shifting supply chains, the counterfeit pills, the overwhelmed coroners, the fundamental dynamic remained the same. The drug supply was becoming more potent, more synthetic, and more unpredictable with every passing year. Users were adapting, developing higher tolerances, demanding stronger product. Dealers were responding to market pressure. And somewhere in the background, in the same chemical ecosystem that had produced fentanyl in the first place, researchers had already synthesized something that made fentanyl look mild. It had been sitting in the scientific literature since 1974. It had been used as a weapon. It had killed people in a Moscow theater. And in 2016, it started showing up in American drug samples, mixed into street products alongside fentanyl, in quantities so small they were nearly impossible to detect, but more than sufficient to kill. There is a rule in pharmacology called the therapeutic index. It describes the ratio between the dose of a drug that produces a useful effect and the dose that kills you. A wide therapeutic index means the drug is forgiving. You can take more than intended and survive. A narrow therapeutic index means the margin between medicine and poison is razor thin. Carfentanil doesn't have a therapeutic index for humans. It was never calculated because no one ever intended to give it to a human being. The entire premise of its existence was that it would be used on animals too large for conventional sedation. Elephants, rhinoceroses, bison, creatures weighing thousands of pounds that needed to be immobilized for veterinary procedures. The effective dose for an elephant is around 2 milligrams. The estimated lethal dose for a human being is somewhere in the range of 20 micrograms. That's 20 millionths of a gram. A particle visible to the naked eye, barely. Carfentanil was first synthesized in 1974 by a team of chemists at Janssen Pharmaceutica, the same company founded by Paul Janssen, the man who created fentanyl 14 years earlier. The lead researcher on the project was a chemist named Paul Janssen himself, working alongside Arnold Jacobson and colleagues who were systematically exploring the fentanyl molecule's chemical neighborhood, testing variations to see what happened when they altered its structure in different ways. What they found when they added a carbomethoxy group to the fentanyl molecule was a compound of staggering potency, approximately 10,000 times stronger than morphine, 100 times stronger than fentanyl. It was the most potent opioid ever synthesized at that point in history. Janssen's team published the finding. They were not secretive about it. The synthesis method, the potency data, all of it went into the scientific literature, accessible to anyone with a chemistry background and a university library card. In veterinary medicine, carfentanil found a legitimate purpose. Under the brand name Wild Nil, it was used by wildlife biologists and veterinarians for large animal immobilization. A dart containing a tiny amount could drop a fully grown elephant in minutes. The handlers working with it wore protective equipment and carried reversal agents at all times, because they understood that skin contact with even a trace amount was potentially fatal. The warning labels were explicit. The protocols were strict. For decades, it remained in that narrow professional context, dangerous but controlled. Then the Soviet Union took notice. The military applications of an aerosolizable opioid compound 10,000 times stronger than morphine were not difficult to imagine. Soviet researchers, and later Russian military scientists, explored carfentanil and related compounds as potential incapacitating agents. Chemical weapons designed not to kill, but to render an enemy population unconscious rapidly and at scale. The precise details of this research program were classified and remain only partially known, but the existence of the program was confirmed by subsequent events. The world learned what Russian military chemists had been working on in October 2002 during a hostage crisis at a Moscow theatre. On October 23rd of that year, a group of Chechen militants seized the Dubrovka Theatre in Moscow during a performance, taking approximately 850 people hostage. The standoff lasted nearly 3 days. On the morning of October 26th, Russian special forces pumped an aerosolized chemical agent through the theatre's ventilation system before launching their assault. The agent was intended to render the hostages and militants unconscious simultaneously, allowing soldiers to enter and neutralize the militants before they could detonate explosive vests. In terms of tactical objective, stopping the militants, it worked. In terms of human cost, it was catastrophic. Of the 850 hostages, at least 130 died, nearly all of them from the effects of the gas rather than from the militants. Subsequent analysis of survivors and victims strongly indicated the agent was a carfentanil-based aerosol, possibly mixed with halothane. Russian authorities initially refused to identify the substance, which meant that the doctors treating survivors didn't know what reversal agent to use. People died in ambulances and hospital corridors from respiratory depression, while physicians struggled to understand what they were dealing with. The Russian government eventually acknowledged that an opioid-based agent had been used but never confirmed the exact formulation. The incident became a case study in the gap between a weapon's intended effect and its actual consequences when deployed in an uncontrolled environment. It also put carfentanil's name in international security discussions for the first time, as analysts debated whether its use constituted a violation of the Chemical Weapons Convention. For the next 14 years, carfentanil remained a subject of concern primarily in defense and security circles. Street drug analysts weren't thinking about it. Law enforcement toxicology labs weren't testing for it. It existed in a conceptual space somewhere between legitimate veterinary medicine and classified weapons research, and neither space had obvious relevance to the American opioid crisis. In the summer of 2016, a toxicology laboratory in Hamilton, Ontario received a sample from an overdose case that didn't fit expected profiles. The fentanyl concentration was insufficient to explain the severity of the overdose on its own. The lab ran additional screens and found carfentanil. It was the first confirmed detection of carfentanil in an illicit street drug sample in North America. Within weeks, similar findings emerged from labs in Ohio, Kentucky, and Indiana. The detections accelerated. By the end of 2016, Carfentanil had been confirmed in drug samples across multiple US states and Canadian provinces. The speed of its spread was alarming, but the more disturbing question was how it had gotten there. Carfentanil was not a drug that people were specifically seeking. Nobody was asking their dealer for elephant tranquilizer. What was happening was that carfentanil had become an adulterant, a substance added to other drugs to increase potency at minimal cost. For a manufacturer in China producing fentanyl analogues by the kilogram, adding a small percentage of carfentanil to a batch was a straightforward way to make the product more potent without significantly increasing production costs. The buyers, American dealers purchasing wholesale quantities, often had no idea what was in the mixture, and the users at the end of the chain had absolutely no way of knowing. The toxicology challenge alone was severe. Most standard drug testing panels, including the immunoassay screens commonly used in hospital emergency departments, were not designed to detect carfentanil. The molecule was present in such tiny quantities, because tiny quantities were all that was needed, that it fell below the detection threshold of tests calibrated for fentanyl. A sample could test positive for fentanyl, which satisfied the clinical picture of an opioid overdose, while carfentanil sat undetected in the same sample, having contributed the majority of the lethal effect. Medical examiners across the Midwest began requesting confirmation testing specifically for carfentanil after the Hamilton Lab's findings circulated through professional networks. Many labs didn't have the reagents, others had the equipment, but not the reference standards needed to calibrate the test. Months passed between the first street detections and the point where reliable testing was widely available, meaning an unknown number of overdose deaths in that period were attributed to fentanyl when carfentanil was the actual or contributing cause. First responders encountered a different problem entirely. Fentanyl was already known to pose a skin absorption risk in large quantities, though epidemiological evidence suggested this risk was lower than initially feared. Carfentanil, at 100 times fentanyl's potency, was another category of hazard. Law enforcement officers and paramedics responding to scenes involving suspected carfentanil were advised to treat the substance as a contact hazard, avoid any direct skin exposure, and carry personal protective equipment including gloves and face coverings. Several documented cases involved first responders experiencing symptoms: dizziness, difficulty breathing, altered consciousness, after responding to scenes with suspected carfentanil present. The DEA issued officer safety alerts. Police departments began revising their protocols for approaching overdose scenes. The psychological effect on first responders was significant and largely invisible in the public conversation about the opioid crisis. Paramedics who had spent years responding to overdose calls, a difficult but manageable part of the job, were now being told that the substance they might encounter could incapacitate them through accidental contact. The job hadn't just become harder, it had become physically dangerous in a new way. Some departments began equipping officers with naloxone not just for overdose victims, but for use on themselves in case of accidental exposure. Carfentanil's arrival in the street drug supply also exposed a critical limitation of naloxone, the overdose reversal drug that had become the centerpiece of the public health response to the fentanyl crisis. Naloxone works by binding to opioid receptors and displacing the opioid, essentially evicting fentanyl or heroin from the receptors and restoring normal breathing. Against standard fentanyl, multiple doses of naloxone could typically reverse an overdose, though sometimes 3 or 4 doses were needed where one had previously been sufficient. Against carfentanil, the binding affinity was so much stronger that naloxone struggled to compete. Paramedics began reporting cases where 6, 8, 10 doses of naloxone produced only partial reversal. The antidote wasn't failing completely, but it was losing ground fast. And while first responders were calculating how many more doses to administer, The clock on brain damage from oxygen deprivation was ticking. The DEA emergency scheduled carfentanil in September 2016, making it a Schedule 1 controlled substance. The scheduling was appropriate and necessary. It was also, by that point, largely reactive. Carfentanil was already distributed across the North American drug supply, mixed into products that people were using daily, in quantities that no regulatory action could recall. The molecule existed in the world now, in the hands of people who had no training in handling it and no interest in the warnings printed on veterinary sedative containers. What the scheduling did accomplish was to push carfentanil synthesis further underground and further east, tightening the connection between illicit drug manufacturing and the networks already producing fentanyl analogues. And in those same networks, in the same clandestine labs and grey zone chemical operations, the mixing had already begun. Not just carfentanil with fentanyl, but carfentanil and fentanyl combined with older opioids, combined with novel synthetic compounds, combined into a mixture so chemically complex and so variably dosed that it defied any single description. What emerged from that mixing had a name, given to it not by the people who made it, but by the people who first identified it on a laboratory bench in Georgia, staring at a grey, chunky, cement-like powder that didn't match anything in their reference database. The name came from the appearance. Grey death looked like concrete mix, chunky, greyish, irregular in texture, nothing like the fine white powder of pharmaceutical fentanyl or the brown tar of Mexican heroin. It looked industrial. It looked like something you'd find at a construction site, not something a person would voluntarily put into their body. But appearances in the drug world are almost always misleading, and Grey Death's appearance was the least remarkable thing about it. What mattered was the chemistry underneath, a combination of substances so potent, so variable, and so poorly understood that even the analysts who first characterized it struggled to explain how any single dose could be survivable at all. The baseline components identified in early Grey Death samples were heroin, fentanyl, carfentanil, and a synthetic opioid called U47700. That last compound deserves particular attention because most people outside of pharmacology research had never heard of it, and its presence in a street drug represented something genuinely new in the history of the opioid crisis. U47700 was not invented in a clandestine lab. It was synthesized in the 1970s by scientists at the pharmaceutical company Upjohn. The U in the name stands for Upjohn, and the number is simply the compound's identifier in the company's research catalogue. Upjohn's chemists created it as part of a systematic exploration of opioid chemistry, searching for a compound that might have clinical applications. U47700 was found to be approximately 7.5 times more potent than morphine. In animal studies, it showed promise. It was never developed into a pharmaceutical product, never approved for human use, never manufactured commercially. It existed only in research papers and laboratory notebooks, a chemical curiosity that the scientific community had largely forgotten about by the time the 1980s arrived. 40 years later, someone in China read those old papers. The same grey zone chemical manufacturers who had been producing fentanyl analogues began synthesizing U47700 around 2015. It was technically legal under Chinese law at the time, unscheduled in most American states, and detectable by almost none of the standard drug screening panels in use at hospitals and medical examiners' offices. It offered a useful combination of properties for someone manufacturing an illicit product: high potency, legal ambiguity, and near invisibility to testing. It began appearing in drug samples in the United States in 2015, initially in isolation, and then, increasingly, mixed with other compounds. The DEA emergency scheduled 47,700 in November 2016. By then, it had been linked to dozens of overdose deaths across the country, and more significantly, it had already been incorporated into the mixture that would become Grey Death. Understanding why the combination of these four substances is so dangerous requires a brief detour into receptor pharmacology, but the concept is simpler than the terminology suggests. The brain's opioid receptors are not all identical. There are three primary types, mu, delta, and kappa, and different opioids bind to them with different affinities and at different speeds. Heroin acts primarily on mu receptors and takes effect relatively slowly compared to synthetic opioids, with a duration of several hours. Fentanyl hits mu receptors with far greater intensity and much faster onset, effects within minutes. Carfentanil binds with even greater affinity and extraordinary duration, meaning it stays attached to receptors longer and is harder to displace. U-47,700 has a distinct binding profile that differs subtly from the others, affecting the receptor response in ways that don't simply add to the other compounds, but interact with them in complex, incompletely understood ways. When all four are present in a single dose, the effect on the brain's opioid receptor system is not simply the sum of the parts. The different compounds arrive at different speeds, occupy receptors with different tenacities, and produce overlapping waves of respiratory depression that hit the brainstem in a sequence rather than a single pulse. A person might seem to stabilize briefly, the faster-acting fentanyl producing an initial effect that then appears to plateau, before the carfentanil's slower, deeper binding takes hold and drives respiration down further. From the outside, this could look like partial recovery followed by sudden deterioration. First responders who administered naloxone and watched a patient briefly improve, then assumed the situation was stabilizing, were sometimes caught off guard when the patient deteriorated again minutes later. But perhaps the most dangerous characteristic of Grey Death wasn't any single ingredient. It was the absence of any consistent recipe. Unlike pharmaceutical products manufactured under regulated conditions with precise quality control, Grey Death was produced by people whose primary qualification was access to ingredients. The mixing process happened at multiple levels of the supply chain, sometimes at the wholesale level, sometimes by mid-level dealers cutting their product, sometimes at the retail level by people who had no instruments more sophisticated than a kitchen scale, and sometimes not at all, meaning the apparent consistency of the product within a single batch masked enormous variation between batches. Two purchases of what appeared to be identical Grey Death, bought from the same dealer within the same week, could have wildly different carfentanil concentrations. One might be survivable, the other might not. The phenomenon of hotspots, uneven distribution of active compounds within a mixed powder, made this even worse. When powders of different densities and particle sizes are mixed together without industrial equipment, they don't blend uniformly. They stratify. Heavier particles settle, lighter ones rise. A bag that has been sitting undisturbed might have a higher concentration of carfentanil at the bottom than at the top. A user who shook the bag before measuring their dose got a different product than one who scooped from the top. This was not theoretical. Forensic chemists examining Grey Death samples documented significant concentration variation between different portions of the same submitted sample, meaning the batch was not only unpredictable between purchases, but potentially between individual uses of the same purchase. The grey colour itself was a clue that nobody was running quality control. Pure fentanyl is white. Pure heroin ranges from white to brown, depending on processing. Carfentanil in pure form is white. U-47,700 is white to off-white. None of the constituent compounds were grey. The colour came from the mixing process itself, from the combination of different substances, cutting agents, binding materials, and whatever residues and contaminants were introduced during production. The grey, concrete-like appearance was evidence of improvised manufacturing. It was the visual signature of a product assembled without standards, oversight, or any coherent quality assurance process. Some samples of grey death contained additional compounds beyond the 4 primary components. Acetyl fentanyl, another fentanyl analogue, appeared in certain batches. Furanyl fentanyl, which had been circulating in the drug supply since approximately 2016, appeared in others. Xylazine, a veterinary sedative that is not an opioid and therefore not reversed by naloxone, was detected in some samples, though its widespread adulteration of the fentanyl supply became more pronounced in subsequent years. Each additional compound represented another variable in an already incalculable equation. Laboratory analysts examining grey death samples sometimes found 5 or 6 distinct psychoactive compounds in a single submission. They were not looking at a drug. They were looking at an accidental polypharmacy experiment being conducted on human subjects without their knowledge or consent. The harm reduction community, the network of public health workers, needle exchange programs, and community organizations that work directly with people who use drugs, responded to grey death with a combination of alarm and pragmatism. Fentanyl test strips, which could detect the presence of fentanyl in a drug sample, had been slowly gaining acceptance as a harm reduction tool despite being classified as drug paraphernalia in many states. But fentanyl test strips didn't detect carfentanil reliably. They also didn't detect U47700. A sample that tested positive for fentanyl using a standard strip might also contain carfentanil, and the strip would give no indication of this. A sample that tested negative for fentanyl might still contain U47700. The tools that the harm reduction community had fought politically and logistically to make available were technically insufficient for the specific threat that grey death represented. The gap between what testing could confirm and what the sample actually contained was not a minor analytical footnote. It was the difference between a person believing their dose was a known quantity and a person making a potentially fatal decision based on incomplete information. The strips were still better than nothing. Detecting fentanyl in a sample was important information even if it wasn't complete information. But grey death had exposed a ceiling in the harm reduction toolkit that would require new technology and new resources to address. By the time public health officials and law enforcement fully understood what grey death was composed of, it had already been circulating in the southeast for months. The first formal identification had happened not in a well-funded federal laboratory, with advance warning and specialized equipment, but in a state crime lab in Georgia, during a routine examination that turned out to be anything but routine. The analyst who first documented it didn't know what she was looking at. She knew what the individual components were once she identified them. What she couldn't immediately explain was why they were together, who had made this combination, and how many more samples like it were already in circulation. The answer to that last question was more alarming than anyone in that laboratory had yet imagined. Georgia was not the obvious epicenter for a new drug crisis. The states that had dominated opioid overdose headlines through the early 2000s were Ohio, West Virginia, Kentucky, and New Hampshire, places with deep histories of prescription pill abuse, collapsed industrial economies, and communities already hollowed out by a decade of pharmaceutical-driven addiction. Georgia had its opioid problems, but it wasn't the state that public health researchers watched most closely when tracking the frontier of the crisis, which is precisely why what happened there in the spring of 2017 caught almost everyone off guard. The Georgia Bureau of Investigation's Division of Forensic Sciences processed drug evidence submitted by law enforcement agencies across the state. The laboratory in Decatur handled thousands of submissions annually: cocaine, methamphetamine, marijuana, various prescription drugs, and increasingly synthetic opioids. The analysts there were experienced and well equipped by state laboratory standards. They had been seeing fentanyl in submissions for several years, and the protocols for identifying and documenting it were established. When samples began arriving in early 2017 that didn't fit the expected fentanyl profile, the analysts didn't immediately know what they were looking at. The appearance was wrong. The preliminary screening results were unusual, and the more detailed analysis revealed a combination of compounds that nobody in that laboratory had ever seen assembled together in a single sample. The formal identification required confirmation testing and reference comparisons that took time. But the urgency was impossible to ignore, because the samples weren't arriving in a vacuum. They were arriving alongside reports of overdoses that were behaving differently from anything first responders in the state had previously encountered. Naloxone wasn't working the way it should. People were dying faster. The clinical picture of these overdoses was more severe, more resistant to intervention, and more rapidly fatal than the fentanyl overdoses that Georgia's emergency medical services had spent the previous 2 years learning to manage. The GBI's formal public alert about grey death came in May 2017. The announcement was precise and deliberately alarming, because the people drafting it understood that the standard public health messaging about opioid overdoses, call 911, use naloxone, put the person in the recovery position, was insufficient for what they were describing. The alert warned that grey death could be absorbed through the skin. It warned that standard naloxone doses might not be enough to reverse an overdose. It warned law enforcement and first responders to treat any encountered substance resembling the described material as an extreme hazard. The language was not bureaucratic. It was the language of people who had looked at the laboratory results and understood that something genuinely new and genuinely worse had arrived. The geographic pattern of the initial cases was instructive. Grey death didn't appear first in Atlanta, Georgia's largest city, and the logical entry point for drug distribution networks serving the southeast. It appeared in smaller cities and suburban areas, places like Warner Robins, Albany, and communities along the 75 corridor that connected Atlanta to Florida. This distribution pattern suggested that grey death was entering Georgia not as a product specifically targeted at the Atlanta market, but as something moving through existing distribution channels that happened to pass through these communities. The supply chain logic pointed south, toward Florida, which had its own long and complicated history as both a destination and a transit point for drug distribution. Florida's connection to the grey death story was significant. The state had been the epicenter of the prescription pill mill crisis in the late 2000s and early 2010s, when hundreds of pain clinics operated with minimal oversight, prescribing opioids to patients who drove from across the country specifically to obtain them. Florida had eventually cracked down hard on the pill mills. By 2012, enforcement actions had closed most of them and dramatically reduced prescription opioid availability. The people who had been obtaining pills through those clinics suddenly needed an alternative, and the alternative was heroin and then fentanyl, moving through the same distribution networks that had served the pill mill customers. By the time grey death appeared, Florida had an established and hungry synthetic opioid market that was well connected to supply networks with reach across the entire southeast. Within weeks of the GBI's public alert, confirmed grey death samples were being reported in Alabama and Ohio. Within 2 months, Pennsylvania and Indiana had their own confirmed cases. The spread wasn't random. It followed the logic of drug distribution networks. The same routes, the same wholesaler-to-dealer chains, the same geographic corridors that moved every other drug product. Grey death was not being specially distributed. It was flowing through existing channels as one product among many, distinguished only by its exceptional lethality. The emergency rooms in communities where grey death was circulating began encountering overdose presentations that fell outside their established protocols. The standard response to an opioid overdose, administer naloxone, support breathing, monitor, was producing incomplete results. Patients received 2 doses of naloxone and showed minimal response. A 3rd dose produced slight improvement that didn't hold. A 4th and 5th dose bought time but didn't resolve the crisis. The physicians managing these cases were making real-time decisions without clear guidance, because the clinical literature on carfentanil poisoning in humans was essentially limited to the Moscow theatre incident, and the circumstances there, mass aerosol exposure, unknown concentration, no medical records for victims, were not directly applicable to individual street-level overdose management. One documented case from the Atlanta area illustrated the problem with particular clarity. A patient arrived at an emergency department unresponsive, with respiratory depression severe enough to require mechanical ventilation. Standard overdose management was initiated. Over the following 2 hours, the patient received an amount of naloxone that would have been sufficient to reverse the effects of a massive heroin overdose many times over. The opioid toxidrome partially resolved but kept reasserting itself. The clinical team eventually used a continuous naloxone infusion, a technique typically reserved for long-acting opioid poisonings, to maintain any level of reversal. The patient survived but required an extended ICU stay. The toxicology later confirmed carfentanil as a primary component of what had been consumed. Cases like this one spread through emergency medicine networks and professional listservs quickly. Physicians who had never seen carfentanil outside of a toxicology textbook were suddenly managing it in community hospitals with limited resources. The information gap was stark. There were no clinical guidelines for carfentanil overdose management, because no guidelines had ever needed to exist. Physicians were improvising based on first principles and sharing experiences with colleagues in real time, building an informal clinical knowledge base out of necessity, while patients arrived in waves. The public health infrastructure in Georgia mobilized faster than in most states, partly because the GBI's early identification had provided crucial lead time, and partly because Georgia had already invested in expanding naloxone access and training following the fentanyl surge of the preceding years. Harm reduction organizations were contacted directly and briefed on the new threat. Community naloxone distribution programs were told explicitly that their standard messaging, carry 2 doses, was inadequate for grey death exposures, and that people should carry as much naloxone as they could obtain. The advice was well-intentioned and practically difficult to implement, because naloxone had a cost, and the communities most exposed to grey death were also the communities with the fewest resources. Law enforcement officers across Georgia were being briefed on the contact hazard protocol simultaneously. The practical implications of those protocols created friction in the field. Officers responding to calls involving suspected overdoses were now being told to don gloves before approaching, to avoid touching any powder residue, and to be alert to their own symptoms. For patrol officers accustomed to providing immediate first aid at overdose scenes, the new protocols introduced hesitation at exactly the moment when speed was most critical. Several departments grappled openly with the tension between officer safety and patient outcomes, acknowledging that the time required to put on protective equipment before approaching an unconscious patient was time that patient might not have. The media coverage of grey death in the summer of 2017 was extensive and in some cases counterproductive. Several major outlets ran stories framing the contact hazard in terms that significantly overstated the skin absorption risk, producing reports suggesting that police officers could overdose from simply being near the substance. The DEA and several toxicologists pushed back on the most extreme claims, noting that while caution was warranted, the risk of fatal incapacitation from casual proximity was not supported by the available evidence. But the damage to public understanding had been done. The narrative of grey death as something that could kill you by existing near it, while not entirely accurate, was already embedded in the public consciousness. What the media coverage did accomplish, despite its inaccuracies, was to force a national conversation about how far the opioid crisis had evolved from its origins in prescription pill overprescribing. The substance being discussed in the summer of 2017 bore almost no resemblance to OxyContin. It had no pharmaceutical origin, no clinical history, no regulatory pathway. It was a product of chemical improvisation, market pressure, and the accumulated recklessness of a supply chain that had been operating without any constraints for years. And it was spreading with a speed that suggested the GBI's alert had come not at the beginning of the Grey Death crisis, but somewhere in the middle of it. The question that nobody in Georgia, or Ohio, or Alabama, or Pennsylvania could yet answer was how many people had already died from Grey Death without it being identified. How many overdose deaths in the preceding months had been attributed to fentanyl because the laboratories testing the samples weren't looking for carfentanil or 47,700. How long had Grey Death been circulating before the analyst indicator had first looked at that grey, concrete-textured powder and known that something was wrong? The honest answer was that nobody knew, and the implications of not knowing were about to become much harder to ignore. Naloxone was supposed to be the part of the opioid crisis story where something worked. It had been around since 1961, developed just 1 year after fentanyl by a chemist named Jack Fishman at a pharmaceutical company called Sankyo. For decades it sat in hospital emergency departments as a specialist tool, used primarily by anesthesiologists and emergency physicians managing overdoses in controlled settings. It wasn't glamorous. It wasn't profitable enough to market aggressively. It was simply effective, a molecule that fit the opioid receptor like a key but carried no opioid effect of its own, effectively evicting heroin or morphine from the receptor and restoring normal breathing within minutes. In the clinical world, it was considered one of the cleaner pharmacological interventions in medicine. The mechanism was elegant, the effect was fast, and the safety profile was excellent. The push to make naloxone widely available outside hospitals began in earnest in the early 2000s, driven largely by harm reduction advocates who understood that most opioid overdose deaths occurred not in emergency rooms but in private spaces, bedrooms, bathrooms, cars, where the person who found the victim had no medical training and no tools. The logic was straightforward. If an overdose could be reversed by a bystander in the first few minutes, before permanent brain damage from oxygen deprivation set in, thousands of lives could be saved annually. The barriers were political rather than medical. Naloxone required a prescription in most states. Distributing it to drug users and their families meant acknowledging that those people existed and that their lives were worth saving, a position that proved surprisingly controversial in certain policy environments. By 2014, the political and public health consensus had shifted sufficiently that naloxone access was expanding rapidly. The FDA approved a nasal spray formulation called Narcan that required no medical training to administer. States began passing laws allowing pharmacists to dispense naloxone without a prescription. Community organizations received federal funding to distribute it. Police departments began equipping officers. The overdose reversal rate improved measurably in communities where naloxone distribution was active. It wasn't solving the addiction crisis, but it was keeping people alive long enough to have the option of treatment. In the arithmetic of public health interventions that counted as success, then fentanyl changed the equation. Heroin overdoses typically unfolded over a time frame of several minutes, allowing a bystander who discovered an unconscious person to call emergency services and administer naloxone with a reasonable chance of effective intervention before severe brain damage occurred. Fentanyl overdoses were faster and more severe. The time window between loss of consciousness and irreversible hypoxic brain injury compressed significantly. 2 milligrams of naloxone, the standard dose in most community distribution programs, often reversed heroin overdoses completely. Against fentanyl, 2 milligrams sometimes produced only partial reversal, requiring additional doses. Emergency protocols began recommending that first responders administer multiple doses in rapid succession if the initial dose produced an insufficient response. Paramedic services across the country began quietly revising their fentanyl overdose protocols upward. More naloxone, faster administration, longer observation periods before clearing a scene. The revision process was driven by field experience rather than formal guideline changes, which meant it was uneven and inconsistent across different services. Some departments were administering 4 doses as standard protocol for suspected fentanyl overdoses by 2016. Others were still operating on 2-dose protocols designed for heroin. The gap between best practice and standard practice was measured in lives. Carfentanil made the gap catastrophic. The binding affinity of carfentanil for the mu-opioid receptor is so much greater than naloxone's that the competitive pharmacology becomes deeply unfavorable. Naloxone works by outcompeting the opioid for receptor binding. It has to be present in sufficient concentration to displace what's already there and prevent reattachment. Against heroin or standard fentanyl, standard doses achieve this. Against carfentanil, the affinity mismatch means that achieving full receptor displacement requires concentrations of naloxone that the standard dosing regimens simply don't produce. More naloxone can overcome this. The competitive dynamics aren't absolute, but more naloxone means more doses, more time, more resources, and more risk of the interval between doses being too long. The documented cases from the 2017 Grey Death outbreak illustrated this with brutal consistency. A paramedic crew in Cincinnati responding to a suspected Grey Death overdose administered the first 2 doses of naloxone within the first minute of patient contact, per their updated fentanyl protocol. Minimal response, 2 more doses, partial response. Breathing improved slightly but remained dangerously shallow. 2 more doses. The patient stabilized enough for transport. Total naloxone administered before hospital arrival. 6 doses. 3 times the amount that would have been unambiguously sufficient for any fentanyl overdose recorded in that department's history the previous year. At the hospital, the patient received a continuous naloxone infusion for the next 14 hours before the clinical team felt confident discontinuing it. The carfentanil's receptor binding had been so tenacious that the reversal required not a burst of antidote but a sustained hours-long biochemical siege. Multiply that case across hundreds of emergency departments and thousands of paramedic calls, and the systemic implications become clear. Naloxone was not cheap at the scale being deployed. Each Narcan nasal spray device cost between $20 and $150, depending on the purchasing arrangement. A department using 6 doses per call instead of 2 was tripling its per-incident naloxone expenditure. Statewide, in regions where Grey Death had achieved significant market penetration, the naloxone budget requirements escalated faster than budget allocations could follow. Several harm reduction organizations reported shortages, not because naloxone was unavailable nationally, but because local procurement systems weren't designed for this consumption rate. A resource that had been considered reliably available was becoming intermittently scarce at exactly the locations where it was most needed. The community naloxone distribution programs faced an additional problem beyond supply. The 2-dose kits they had been distributing, standard for years, adequate for heroin, workable for fentanyl, were insufficient for Grey Death. The messaging that had accompanied those kits, carefully calibrated to be simple enough for a panicking bystander to follow, said, "Administer 1 dose, wait 2 to 3 minutes, administer a second dose if no response, call 911. Against carfentanil, following this protocol precisely could result in a person receiving 2 doses of naloxone, showing minimal improvement, and dying while the bystander waited for the ambulance, having administered what they believed was the correct intervention. The protocol wasn't wrong for the drug it was designed for. It was simply designed for a different drug. Updating the community messaging required navigating a communication challenge that public health officials hadn't previously encountered. Telling people to administer more naloxone was straightforward. Explaining why, without generating panic or undermining confidence in the drug's effectiveness, required threading a needle. If communities believed naloxone didn't work against the drugs now circulating, they might stop carrying it, which would be catastrophically counterproductive. Naloxone did work against grey death. It just worked less easily, required more doses, and needed to be followed by professional medical care more urgently than ever. The nuance of that message was difficult to compress into the format of a harm reduction handout. The emergency medical community simultaneously confronted a training deficit. Paramedics and EMTs who had received training on opioid overdose management in 2015 or 2016 had been trained for a fentanyl environment. That training was now partially obsolete. The specific clinical challenges of carfentanil, prolonged receptor occupation, recurring respiratory depression after apparent stabilization, the need for continuous infusion rather than bolus dosing in severe cases, required updated knowledge that was only slowly making its way through continuing education programs. Field providers were encountering clinical situations their training hadn't prepared them for, making real-time decisions with incomplete information in the back of ambulances with families watching. The psychological burden on emergency medical personnel during this period was substantial and inadequately acknowledged. Paramedics who had built professional identities around their ability to reverse opioid overdoses, who had come to see naloxone administration as a reliable, almost routine intervention, were suddenly losing patients they had treated correctly. The naloxone had been given, the doses had been appropriate, the response time had been fast, and the patient had died anyway. The professional and emotional weight of that outcome, repeated across shifts and across years, contributed to the broader burnout crisis affecting emergency medical services during this period. Grey Death didn't just challenge pharmacology, it challenged the confidence of the people deployed to fight it. The pharmaceutical industry, watching the naloxone demand surge, responded with higher dose formulations. A 4 mg nasal spray replaced the earlier 2 mg version as the standard community product. An 8 mg formulation was developed and approved for distribution. These higher doses improved the response rate against grey death exposures and reduced the number of sequential doses needed in many cases. They also cost more, required updated distribution infrastructure, and arrived on the market later than the crisis demanded. The gap between what the drug supply had become and what the public health response had prepared for remained stubbornly wide. Meanwhile, in the toxicology laboratories processing overdose evidence, and in the emergency departments managing survivors, a pattern was becoming visible that pointed towards something beyond the pharmacological challenge. The people dying from grey death weren't dying randomly. They were concentrated in specific communities, specific demographics, specific social circumstances. The drug was catastrophically dangerous to everyone who encountered it, but it was not encountering everyone equally. The distribution of grey death across American communities followed the same contours as poverty, as lack of healthcare access, as histories of trauma and economic marginalization. The antidote was losing its battle, not just because of receptor pharmacology, but because of everything that determined who had access to naloxone, who had someone nearby when they lost consciousness, and who lived in a community with enough emergency medical resources to respond in the critical first minutes. The chemistry was the most visible part of the crisis. The infrastructure failure underneath it was deeper, older, and considerably harder to reverse with a nasal spray. To understand why Grey Death proliferated so rapidly after its initial identification, it's necessary to look at the drug trade not as a moral failure but as a market, one with its own supply chains, pricing pressures, competitive dynamics, and incentive structures. This is uncomfortable, because applying economic logic to a substance that killed thousands of people feels like a kind of endorsement. It isn't. It's a recognition that Grey Death didn't spread because individual dealers were uniquely evil. It spread because the market conditions that produced it were almost perfectly designed to reward its existence. The fundamental economics of the illicit opioid trade by 2017 were driven by one overriding pressure: the cost of potency. A dealer's profit margin was not determined by how much product they sold by weight. It was determined by how much effect they could deliver per dollar of wholesale cost. Heroin, which had dominated the opioid street market for decades, was expensive relative to its potency. Processing, transportation, distribution, across multiple layers of the supply chain. All of it added cost before the product reached the end user. Fentanyl had already disrupted this calculation dramatically. A kilogram of fentanyl purchased wholesale for a few $1,000s could be diluted into a volume of product worth hundreds of thousands of dollars at retail. Carfentanil pushed this logic further still. A single kilogram of carfentanil, at its effective dose of micrograms, represented a quantity of active compounds sufficient to adulterate an almost incomprehensible volume of street product. The cost per unit of effect dropped towards zero. For a mid-level dealer receiving wholesale product, the financial logic was straightforward even if it was never consciously articulated. More potent product sold faster because users reported stronger effects. Stronger effects generated repeat business and word of mouth in the specific dark economy of street drug markets. Product that moved fast reduced the dealer's exposure time, the period during which they held inventory and faced legal risk. The incentives all pointed in the same direction, and none of them included any mechanism for considering whether the product might kill the customer. The absence of quality control wasn't negligence in the traditional sense. It was structural. A licensed pharmaceutical manufacturer operates under regulatory oversight, faces civil liability for product defects, and has institutional reasons to ensure consistency. An illicit drug dealer operates under none of these constraints. There was no agency to inspect the mixing process, no liability attorney waiting to file suit if a batch was too potent, no reputational consequence that couldn't be managed by moving to a different neighborhood or changing a phone number. The accountability mechanisms that force quality control in legitimate markets simply didn't exist. What made Grey Death particularly insidious from a market perspective was that its dangers were invisible to the people purchasing it. A drug that reliably killed its customers should, in theory, be a market failure. Dead customers don't make repeat purchases. But opioid addiction creates a demand structure unlike almost any other consumer market. Physical dependence means that the user's priority is obtaining the drug to prevent withdrawal, not evaluating its safety profile. A person in active opioid withdrawal is experiencing a physical crisis severe enough to override most risk calculations. The concept of comparison shopping for a safer product was largely theoretical for people in that physiological state. The market's normal self-correcting mechanism, consumers avoiding products that harm them, was broken at the point of maximum leverage. The supply chain that delivered Grey Death to street level was also structured in ways that distributed ignorance as efficiently as it distributed product. At the top of the chain, Chinese chemical manufacturers were selling compounds in wholesale quantities with no knowledge of or interest in their end use. Their customers were ordering online, paying in cryptocurrency, providing no information about intended application. The manufacturer's legal exposure was minimal, as long as the compounds were unscheduled under Chinese law. When China scheduled fentanyl analogues in 2019, the manufacturers simply reformulated or shifted production. The institutional knowledge and chemical infrastructure remained intact. The next level of the chain, the importers and wholesale distributors in the United States, were often operating with genuine uncertainty about the precise composition of what they had purchased. A wholesale buyer who had ordered fentanyl powder from an online vendor was receiving whatever the vendor had synthesized or sourced, which might be one compound or several, in proportions that varied between batches. Some wholesale buyers did basic testing. Most didn't, because testing was a cost, a delay, and a risk. Maintaining drug testing equipment was evidence of drug dealing. The information that would have been necessary to make informed decisions about product safety was systematically unavailable at every level of the chain. Mid-level dealers cutting wholesale product into street doses operated with even less information. The standard cutting process, taking a quantity of powder and mixing it with a bulking agent to increase volume while maintaining apparent consistency, worked reasonably well when the active compound was heroin, whose potency was relatively predictable within normal supply chain variation. Applied to a mixture containing carfentanil, whose lethal dose was measured in micrograms, the same process was essentially random. A dealer who bought a kilogram of mixed product from their wholesaler and cut it 50% with lactose was working with a substance whose carfentanil concentration they didn't know, couldn't measure without specialized equipment, and might vary significantly even within the original kilogram due to the hot-spotting phenomenon documented in forensic analyses. The deaths that resulted from this chain of distributed ignorance were not, in most documented cases, the intended outcome of anyone's deliberate decision. This is not an exculpatory argument for the people involved in the supply chain. It is a structural observation about why the crisis was so difficult to address through law enforcement interdiction alone. Arresting a street-level dealer who didn't know what was in their product didn't remove the product from circulation. It removed one node in a network that had dozens of replacements and a supply chain that operated independently of any individual node's continued participation. The tolerance arms race running in parallel with these supply chain dynamics added another layer of pressure. Long-term opioid users develop tolerance, a well-documented physiological adaptation where the same dose produces a reduced effect over time, requiring higher doses to achieve the same result. Users who had been consuming street fentanyl for months or years had developed tolerance profiles calibrated to that level of potency. When Grey Death entered their market, the users with the highest tolerance were paradoxically better positioned to survive initial exposures, not because the drug was safer for them, but because their receptors were already partially occupied by tolerance-related adaptation. Newer users, or users who had recently reduced their intake, including people leaving incarceration or completing short-term detox programs, had no such partial protection and were acutely vulnerable. The market pressure this created was perverse. High-tolerance users reported to their dealers that product wasn't strong enough, creating demand for more potent supply. Dealers who sourced stronger product satisfied this demand and gained market share. The feedback loop rewarded potency escalation at the exact moment when potency escalation was lethal to the most vulnerable part of the user population. The survivors, in a terrible irony, were partly driving the conditions that were killing the least tolerant. Law enforcement's response to Grey Death distribution operated on familiar frameworks: surveillance, controlled buys, arrests, prosecutions, that had been developed for drug markets with different characteristics. A heroin operation could be disrupted by removing key distribution personnel, because heroin supply chains required sustained human relationships and physical logistics that were difficult to rebuild quickly. Synthetic opioid supply chains, built on cryptocurrency transactions, international shipping, and anonymous online marketplaces, were far more resilient to the removal of individual participants. When a distribution network was dismantled, the users it had served didn't stop using. They found new supply through a different channel, often within days, and the new supply came from a different part of the manufacturing ecosystem, with no guaranteed similarity to what had come before. Disrupting supply didn't reduce use, it increased unpredictability. Federal prosecutors pursued grey death cases under enhanced sentencing guidelines that treated carfentanil as a Schedule I substance, with severe penalties for distribution. Several high-profile prosecutions resulted in substantial sentences for distributors found to have knowingly sold carfentanil-containing products. The prosecutions were legally and symbolically significant. Their impact on the overall availability of grey death was negligible, because the supply chain that produced it wasn't headquartered in any American jurisdiction and wasn't meaningfully affected by American sentencing guidelines. The market for grey death operated with its own terrible efficiency. It found customers, maintained supply, adapted to enforcement pressure, and rewarded the people within it who moved fastest and cared least about consequences. It was not a conspiracy. It was an emergent property of a system in which every incentive pointed toward escalation and none pointed toward restraint. And while law enforcement was building cases and public health officials were distributing naloxone, the same chemical infrastructure that had produced grey death was already generating the next iteration. Compounds that hadn't yet been named, hadn't yet been identified in forensic labs, and hadn't yet started appearing in overdose statistics. The market wasn't waiting for anyone to catch up. Numbers have a way of becoming abstract at scale. 20,000 deaths annually from synthetic opioids is a statistic that the mind processes as a large number without fully translating it into human reality. It takes specific documented moments, the kind recorded by coroners, captured in first responder reports, preserved in public health case files, to make the arithmetic visible as something other than data. Grey death produced those moments in concentrated, relentless succession during 2017 and 2018, and the people who witnessed them professionally carried the weight of what they saw long after the immediate crisis had moved on to the next iteration. Huntington, West Virginia, became one of the most documented single-location examples of the synthetic opioid crisis's capacity for concentrated devastation. In August 2016, before grey death had been formally identified, but after carfentanil had already begun infiltrating the regional drug supply, Huntington experienced 28 overdoses in a 4-hour period. A city of 49,000 people, 4 hours, 28 simultaneous overdoses spread across multiple locations, overwhelming the emergency medical services of a city that had neither the personnel nor the equipment to manage that volume of critical patients at once. Ambulances were staged at fire stations waiting for calls because all available units were already deployed. The hospital emergency department was managing multiple critical patients simultaneously, with a staff designed for normal overnight volume. The event became known as the day Huntington almost ran out of ambulances, and it entered the public health literature as a case study in what surge capacity failure looks like in practice. The toxicology from that event pointed toward carfentanil-adulterated product. Not grey death as it would later be formally identified, but the same chemical logic. Fentanyl-class compounds mixed at lethal concentrations, distributed without warning, consumed by people who had no way of knowing what they were taking. Huntington's experience was a preview, a dress rehearsal for what communities across the region would face when the fully formulated Grey Death mixture arrived. In Ohio, Cuyahoga County, which includes Cleveland, recorded 666 overdose deaths in 2017 compared to 399 in 2015. The medical examiner's office, already stretched by the fentanyl surge, was processing a volume of cases that overwhelmed normal operations. Toxicology backlogs stretched to months. Families waited for official cause of death determinations while grief sat unresolved in administrative queue. The medical examiner's office requested emergency staffing support from the state. It wasn't the first time, and the county's public health leadership said openly that the infrastructure for handling mass casualty events, which is essentially what repeated overdose surges represented, had been designed for a different era and a different scale of crisis. The specific geography of overdose deaths within communities told its own story. In city after city, the concentrations were not random. They clustered in neighborhoods where poverty was highest, where housing was least stable, where healthcare access was most limited, and where the social networks that could sustain someone through addiction, family support, stable employment, consistent medical care were most attenuated. Grey Death killed people in affluent suburbs too, as every drug that ever reached the street level eventually did. But its primary geography was the geography of American structural poverty, and the communities absorbing the highest death tolls were communities that had been absorbing concentrated disadvantage for decades before Grey Death arrived. The first responders deployed into this geography carried experiences that didn't translate well into performance reviews or departmental statistics. A paramedic in Cincinnati described arriving at a scene where a mother had administered naloxone to her adult son 3 times before calling 911, following instructions she had memorized from the training she'd received through a community program, watching the drug fail to fully work as promised, calling for help while her son's breathing remained dangerously shallow. The paramedic crew administered additional doses, stabilized the patient, transported him to the hospital. He survived. What the paramedics' report didn't capture, because there was no field on the form for it, was that the mother had performed exactly correctly, had done everything right, and had still watched her son nearly die, because the drug had outpaced the antidote she'd been given. The training had worked. The pharmacology had not. Emergency department physicians developed informal triage instincts for Grey Death presentations that weren't in any medical school curriculum. Patients who didn't respond adequately to the first 2 doses of naloxone got immediate high-dose protocols. Patients who improved and then deteriorated, the recurve pattern characteristic of carfentanil's prolonged receptor binding, were held for observation longer than standard opioid overdose protocols required. Some physicians began keeping patients overnight on the basis of suspected carfentanil exposure, even after clinical stabilization, because the discharge and return cycle, where a patient seemed fine, left the hospital, and returned by ambulance 2 hours later in renewed crisis, was a documented pattern that burned resources and occasionally ended in death. The harm reduction workers who moved through these communities daily occupied a position that was simultaneously essential and largely invisible to the formal healthcare system. They distributed naloxone, ran needle exchanges, maintained relationships with people who wouldn't or couldn't interact with the medical establishment, and were often the first point of contact after an overdose. They were also the ones carrying the informal intelligence about what was in circulation, which batches had caused deaths, which supply sources were more dangerous than others, which neighborhoods were seeing clusters of severe overdoses. This intelligence was passed person to person, written on whiteboards in harm reduction offices, texted through informal networks. It was sometimes faster and more accurate than formal surveillance systems, and it was operating entirely outside of any institutional framework that could systematically collect or act on it. The documented cases of first responder exposure to grey death during this period added a layer of crisis to the crisis. In June 2017, a police officer in East Liverpool, Ohio, a town that had already become one of the most photographed communities in the opioid epidemic, was transported to the hospital after accidentally coming into contact with white powder at the scene of a traffic stop. The officer had handled evidence without gloves, apparently brushed powder from his uniform, and within minutes experienced symptoms consistent with opioid exposure: dizziness, disorientation, difficulty breathing. He received naloxone at the hospital and recovered. The incident was documented extensively, photographed, and reported nationally. The powder was later confirmed to contain fentanyl, not grey death specifically, but the incident crystallized the contact hazard concern that had been building since carfentanil appeared in the drug supply. Law enforcement agencies across affected states used the East Liverpool case to justify stricter protective equipment protocols and to push for expanded naloxone access for officers. Some departments issued personal naloxone kits to every patrol officer. Others installed naloxone in patrol vehicles. The logistics of this expansion were complicated by cost and by the need to train officers in administration, but the underlying calculus was simple. The drug supply had evolved to a point where the people tasked with policing it faced genuine medical risk, and ignoring that risk wasn't an option. The foster care system in heavily affected states registered the downstream social impact in a different dimension. Ohio, West Virginia, and Kentucky saw dramatic increases in foster care placements during the peak years of the synthetic opioid crisis, driven by parental incapacity or death from overdose. In West Virginia, the foster care population grew by more than 40% between 2012 and 2018. State child welfare agencies were overwhelmed. The number of licensed foster families was insufficient for the number of children needing placement, leading to children being housed in office buildings, hotels, and emergency shelters while permanent placements were arranged. These children were the hidden demographic of the grey death crisis, not in the overdose statistics, not in the emergency department records, but present in the data of a child welfare system straining under a load it hadn't been built to carry. Medical examiners in the most affected counties began publishing their data in ways they never previously had, not just annual summaries but monthly or even weekly updates, posted publicly, designed to communicate urgency to elected officials and the public simultaneously. The Cuyahoga County Medical Examiner's Office became something of an accidental public health communications hub, with its director making regular media appearances to translate overdose statistics into human terms. The transparency was partly informational and partly a deliberate strategy, an attempt to force the abstraction of death counts to land with the weight that individual stories carried, multiplied across hundreds of cases month after month. What emerged from this accumulation of documented moments was a portrait of a crisis that was simultaneously individual and systemic, pharmacological and social, immediate and deeply rooted. Each death was a specific person, someone's child, parent, friend, whose final hours were shaped by decisions made in chemical laboratories in China, by the economics of the drug trade, by gaps in the healthcare system, and by the particular circumstances of a life that had arrived at addiction through whatever combination of trauma, biology, circumstance, and inadequate support had brought them there. The chemistry of grey death was terrifying, but the conditions that made it so devastating, the communities with no treatment infrastructure, the families with no support, the first responders with insufficient tools, those conditions had been building for far longer than grey death had existed. The drug hadn't created the vulnerability. It had simply found it, with lethal precision and exploited it at scale. The federal government's primary legal tool for controlling dangerous substances was the Controlled Substances Act of 1970, a framework designed in an era when drug chemistry meant modifying plant-derived compounds in relatively predictable ways. The law established 5 schedules of controlled substances classified by medical utility and abuse potential, with Schedule 1 reserved for drugs deemed to have no accepted medical use and high addiction risk. Adding a substance to the schedule required a formal rule-making process, research, public comment periods, administrative review that typically took months or years. The system was built for a world where new drugs appeared slowly and were developed by identifiable institutions. It was not built for a world where a chemist in Wuhan could synthesize a novel opioid analog on Monday, list it for sale on Tuesday, and have it in American postal packages by Thursday. The DEA had recognized this structural vulnerability as early as the 1980s, during the first wave of designer drug proliferation, when underground chemists began producing analogues of controlled substances that were technically legal because they differed by a molecule from the scheduled compound. Congress responded in 1986 with the Federal Analog Act, which made it illegal to manufacture, distribute, or possess substances that were substantially similar in chemical structure or pharmacological effect to a Schedule 1 or Schedule 2 drug, if intended for human consumption. On paper, it was an elegant solution. Instead of trying to schedule every possible variant, the law captured the entire chemical neighborhood. In practice, the Federal Analog Act was considerably less effective than its drafters hoped. The phrase "substantially similar" became a legal battleground. Defense attorneys argued successfully in multiple cases that the government hadn't proven sufficient structural similarity, or that the pharmacological effect comparison was speculative, or that intent for human consumption couldn't be established when a product was technically sold as a research chemical. The law produced inconsistent results across different federal districts and left prosecutors uncertain about which cases were winnable. Meanwhile, the chemists producing analogues were reading the same case law and adjusting their molecular modifications to maximize distance from scheduled compounds while preserving the desired effect. When carfentanil began appearing in street drug samples in 2016, the DEA moved faster than its normal rulemaking timeline allowed. It used emergency scheduling authority, a provision that allowed the agency to temporarily place a substance on Schedule 1 for up to 3 years, while permanent scheduling procedures were completed, to control carfentanil in September 2016. The emergency scheduling of U-47,700 followed in November of the same year. The agency was reacting with genuine urgency, compressing processes that normally took years into weeks. The scheduling was necessary. It was also, in terms of controlling the actual drug supply, largely symbolic. Emergency scheduling made possession and distribution of the newly controlled substances federal crimes. It did not remove existing inventory from circulation. It did not prevent Chinese manufacturers from synthesizing the compounds while they remained legal under Chinese law. It did not address the dozens of other fentanyl analogues that remained unscheduled. And it did not stop the manufacturers from beginning work on the next generation of compounds, the moment scheduling of the current generation appeared imminent. China's regulatory response to American pressure was halting and politically complex. The United States had been pushing China to schedule fentanyl analogues since at least 2015, arguing that Chinese manufacturers were the primary source of the compounds flooding American streets. Chinese authorities pushed back on the framing, noting that the substances were legal under Chinese law, that their manufacturers were registered businesses, and that the responsibility for controlling drug imports lay with American customs and law enforcement. The diplomatic conversation proceeded slowly through bilateral channels, while overdose deaths accumulated monthly. In May 2019, China announced a blanket ban on all fentanyl-related substances, a sweeping regulatory action that scheduled the entire chemical class rather than trying to enumerate specific analogues. It was the policy outcome American officials had been requesting for years, and it was genuinely significant. Chinese manufacturers who had been operating in legal grey zones were now definitively operating outside Chinese law. The supply of Chinese fentanyl analogues to the American market contracted measurably following the ban's implementation. What happened next illustrated the fundamental limitation of supply-side drug policy with devastating clarity. The Mexican cartels filled the gap within months. The Sinaloa cartel and the Jalisco New Generation cartel had been developing domestic fentanyl synthesis capability since approximately 2015, and by 2019 they had refined their production processes, secured precursor chemical supply chains, sourcing the necessary chemicals from China through obfuscated routes, and integrated fentanyl manufacturing into their existing distribution infrastructure. Where Chinese fentanyl had arrived in the United States primarily through the postal system in small packages, cartel fentanyl moved through the established smuggling corridors that had carried heroin and cocaine for decades. The volumes were enormous, the routes were proven, and the cartels had enforcement and distribution networks on the American side of the border that no Chinese manufacturer could match. The transition from Chinese to Mexican as the primary fentanyl source actually made the American supply problem worse in certain respects. Chinese manufacturers, competing in an open marketplace, had some commercial incentive to deliver a consistent product. Repeat business depended on it. Cartel production, integrated into an already dominant distribution network, faced less competitive pressure to maintain consistency. The fentanyl coming through Mexican supply chains showed greater batch-to-batch variation in concentration and purity than the Chinese product it replaced, contributing to the continued unpredictability of street-level drug potency. The legislative response in Congress during this period produced a series of bills that addressed specific aspects of the crisis without fundamentally altering its trajectory. The Support for Patients and Communities Act, passed in 2018, expanded treatment access, tightened prescribing oversight, and allocated funding for state response programs. It was the most comprehensive federal opioid legislation in decades and represented genuine political effort across party lines. Its treatment expansion provisions saved lives. Its impact on the synthetic opioid supply chain was minimal because the supply chain operated outside the reach of domestic healthcare legislation. The DEA's attempt to prosecute its way out of the crisis produced some high-profile results. Operation Synthetic Opioid Surge, launched in 2018, targeted street-level fentanyl distribution in 10 jurisdictions, resulting in hundreds of arrests. Operation Dark Web, targeting online fentanyl marketplaces, shut down several major darknet drug vendors and resulted in significant seizures. Each operation generated press releases, statistics, and genuine law enforcement effort. Each operation also demonstrated that removing individual participants from the market produced no lasting reduction in supply. Replacement occurred faster than prosecution. The academic chemistry community became an unlikely battleground in the lab wars. The synthesis routes for fentanyl and its analogues had been published in peer-reviewed journals since the 1960s. Carfentanil's synthesis was in the literature. U-47,700 synthesis was in the literature. The molecular modifications required to produce new analogues were the subject of published pharmacology research. None of this research had been published with illicit intent. It was legitimate science produced by legitimate researchers exploring the chemistry and pharmacology of opioid compounds for valid scientific reasons. But the same literature that informed clinical pharmacologists and drug abuse researchers also informed clandestine chemists who used it as a recipe book. Proposals to restrict access to chemical synthesis literature ran into immediate and serious objections from the scientific community, which correctly identified the chilling effect that publication restrictions would have on legitimate research. The tension between scientific openness and the weaponization of published chemistry was real, uncomfortable, and ultimately unresolved. The information couldn't be unwritten. It existed in databases, in libraries, in the memories of thousands of trained chemists around the world. Restricting future publication wouldn't remove existing knowledge, and existing knowledge was sufficient to produce everything that had already appeared in the drug supply and more. The most ambitious legal response to the synthetic opioid crisis was the temporary reauthorization and study of the Emergency Scheduling of Fentanyl Analogues Act, which in 2018 placed all fentanyl analogues, regardless of whether they'd been specifically identified, under Schedule 1 on a temporary basis. It was an attempt to do at the federal level what China had done with its blanket ban, closing the loophole that required specific identification of each new compound before it could be controlled. The temporary scheduling was repeatedly extended as Congress debated permanent authorization. The blanket scheduling approach had genuine merit as a legal strategy, but it carried costs that its proponents acknowledged. Scheduling all fentanyl analogues as Schedule 1 made it significantly more difficult for legitimate researchers to study those compounds for potential medical applications, a concern that was not merely theoretical, given that fentanyl itself had been developed through exactly this kind of analogue exploration. The law's breadth created regulatory obstacles for researchers studying opioid pharmacology in academic settings, requiring licensing and oversight that delayed and in some cases prevented legitimate scientific work. The same net that was cast to catch illicit chemists also caught the researchers who might have developed better treatments. Throughout all of this legislative and regulatory activity, the scheduling, the bans, the operations, the bills, the underlying driver of demand remained entirely unaddressed. People were using drugs because they were in pain, or because they were addicted, or because the social and economic conditions of their lives left them with few alternatives that offered comparable relief. Arresting suppliers without treating the conditions that created demand was, as every public health researcher studying the crisis noted, the equivalent of mopping the floor without turning off the tap. The water kept flowing. And somewhere in the chemical ecosystem that the law was trying to contain, the next compound was already being synthesized. While legislators drafted bills and law enforcement executed operations, a quieter and less publicized effort was underway in clinics, community centers, and public health departments across the country. It produced fewer press conferences and generated less political capital than drug raids or congressional hearings. It also saved more lives per dollar spent than almost any other intervention deployed during the Grey Death crisis. The public health response to synthetic opioids was not a single program or policy. It was a mosaic of approaches, some evidence-based and long-established, others improvised under pressure, and a few genuinely innovative. What distinguished the interventions that worked from those that didn't was a single underlying principle. They treated addiction as a medical condition rather than a moral failing. This sounds obvious stated plainly. It was not obvious in practice because American drug policy had spent decades organized around the opposite assumption. The criminal justice framework that dominated drug policy from the 1970s onward was built on the premise that drug use was a choice, a bad one, subject to punishment, and that sufficient punishment would deter it. The evidence accumulated over 40 years of this approach suggested otherwise. Incarceration rates for drug offences increased dramatically through the 1980s and 1990s, while drug use remained stable or increased. Communities that received the most aggressive law enforcement attention also recorded the highest rates of addiction-related disease and death. The deterrence model wasn't just failing. In some respects, by concentrating disadvantage and disrupting family and community networks, it was actively worsening the conditions that drove drug use. The harm reduction model that began gaining institutional acceptance during the fentanyl crisis operated from a different starting point. It acknowledged that some people would continue using drugs regardless of legal consequences, and that the goal of public health intervention should be to keep those people alive long enough to access treatment if and when they chose to. It was pragmatic rather than moralistic, and its results were measurable. Needle exchange programs, formerly called syringe services programs, were among the most extensively evaluated harm reduction interventions. They reduced transmission of HIV and hepatitis C among people who inject drugs, which addressed a separate and significant public health burden. They also created contact points between injection drug users and health services, regular interactions where participants could be connected to naloxone, tested for infectious diseases, referred to treatment programs, and engaged with healthcare providers in a non-punitive context. Studies consistently found that syringe services programs reduced overdose mortality in the communities where they operated. They also consistently faced political opposition from officials who argued that providing clean needles enabled drug use, a claim not supported by the available evidence, but one that proved resilient to evidence regardless. Fentanyl test strips represented a harm reduction tool specifically calibrated to the synthetic opioid environment. Originally developed for testing MDMA at raves, the strips were adapted to detect fentanyl in any drug sample. A small amount of the drug dissolved in water, the strip dipped in, a result in seconds. Positive result meant fentanyl was present. In the context of a drug supply where heroin, cocaine, and counterfeit pills were all being adulterated with fentanyl, this information was genuinely life-saving. Studies examining communities where fentanyl test strips were distributed found that users who tested positive for fentanyl changed their behavior in measurable ways, using smaller amounts, using more slowly, ensuring someone was present, or in some cases choosing not to use at all. The strips were cheap, simple, and effective. They were also classified as drug paraphernalia in 35 states at the start of the fentanyl crisis, making their distribution illegal in precisely the communities where they were most needed. The legal barrier was not a minor technical obstacle. Organizations distributing strips in states where they were illegal faced real legal risk, and the threat of prosecution was sufficient to prevent distribution in many areas. A multi-year advocacy effort by harm reduction organizations and public health researchers succeeded in changing paraphernalia laws in many states. By 2022, the majority of states had exempted fentanyl test strips from paraphernalia classification. But the window between when the strips were most needed and when they were legally available was measured in years and years of preventable deaths. Medication-assisted treatment, specifically the use of buprenorphine and methadone to manage opioid addiction, was the intervention with the strongest evidence base and the most significant gap between evidence and implementation. Both drugs worked by occupying opioid receptors at a level sufficient to prevent withdrawal and reduce craving without producing the intense euphoria of heroin or fentanyl. They stabilized patients physiologically, allowing them to function, engage in therapy, maintain employment, and rebuild social connections. Decades of research demonstrated that patients receiving medication-assisted treatment had dramatically lower rates of overdose death, lower rates of drug-related infectious disease, and higher rates of sustained recovery than patients in abstinence-only programs. The evidence was unambiguous. The adoption was scandalously slow. Prescribing buprenorphine required a special federal waiver, the Data 2000 waiver, that limited the number of patients a physician could treat, and required additional training. The waiver system had been designed to prevent buprenorphine from becoming a drug of abuse, a concern that, while not entirely unfounded, had been used to restrict access far beyond what the evidence justified. Primary care physicians in rural areas, exactly the physicians whose patients needed treatment most urgently, were largely excluded from prescribing buprenorphine because they hadn't obtained the waiver and lacked the time or resources to do so. Methadone, the older and in many ways more effective treatment option for severe opioid use disorder, could only be dispensed through federally certified opioid treatment programs, specialized clinics that were concentrated in urban areas and absent from the rural and suburban communities where the synthetic opioid crisis was most acute. The geographic mismatch between treatment availability and treatment need was stark and deadly. West Virginia, the state with the highest per capita drug overdose death rate in the country for most of the 2010s, had a fraction of the medication-assisted treatment capacity needed to serve its population of people with opioid use disorder. Patients who sought treatment faced waiting lists measured in weeks or months. They were being told to wait for a medication that could prevent their death, while the drug supply that might kill them was available on 24-hour demand. The asymmetry was grotesque, and it was not accidental. It was the product of decades of policy choices that had defunded treatment infrastructure while investing in incarceration. Vancouver's downtown east side became an internationally studied model of a different approach. Canada's harm reduction framework allowed interventions that remained illegal in most American jurisdictions. The supervised consumption site at Insight, opened in 2003, allowed people to use pre-obtained drugs under medical supervision, with naloxone and trained staff immediately available. In over 2 million visits since its opening, Insight recorded 0 overdose deaths on site. The site also served as a point of engagement with healthcare services. A significant proportion of Insight clients had initiated treatment for addiction through referrals made at the facility. The evidence from Vancouver influenced public health researchers across North America and contributed to the policy arguments for supervised consumption sites in American cities. Pittsburgh's harm reduction community developed an informal early warning system during the Grey Death period that became a model for drug-checking services. Community health workers maintained networks within drug-using populations, collecting samples of drugs in circulation and submitting them for testing. When a particularly dangerous batch was identified, unusually high carfentanil concentration, unknown adulterant, anomalous composition, the information was pushed back out through the same community networks within hours. The system was grassroots, underfunded, and technically operating in legal grey areas in some respects. It was also faster and more granular than any formal surveillance system, and the communities it served credited it with saving lives during specific high-danger events. Baltimore's approach to naloxone distribution during the Grey Death period became a benchmark for scale and reach. The city had been distributing naloxone through harm reduction programs since the late 1990s, earlier than almost any other American city, and had built distribution infrastructure that reached into communities through multiple channels: pharmacies, emergency departments, community organizations, housing programs, and the correction system. People leaving Baltimore's jail received naloxone kits and brief overdose prevention training as part of the discharge process, addressing the documented phenomenon of post-incarceration overdose. The period immediately following release from custody, when tolerance had dropped, but the impulse to use remained, was among the highest risk periods in the trajectory of addiction. The correction system connection was significant beyond Baltimore. People cycling through jails and prisons represented a substantial proportion of the population at highest risk for opioid overdose, and the period immediately following release was documented as one of the most dangerous. Studies from multiple states found that recently released individuals had overdose death rates more than 10 times higher than the general population in the weeks after release. Providing naloxone at discharge was a low-cost intervention with a measurable impact on this risk. Providing medication-assisted treatment inside correctional facilities, which remained the exception rather than the rule, had an even larger impact. Rhode Island implemented system-wide medication-assisted treatment in its correctional facilities starting in 2016 and documented a 60% reduction in overdose deaths among recently released individuals in the 2 years following implementation. The evidence was as clear as any in public health research. Replication across other state systems was agonizingly slow. The lesson that emerged from the interventions that worked was consistent and inconvenient for political systems oriented toward visible enforcement action. Quietly keeping people alive through access to medication, clean equipment, and non-judgmental healthcare generated less political reward than high-profile raids and drug seizures, despite producing better measurable outcomes. The communities that invested in harm reduction infrastructure during the Grey Death period emerged with lower death tolls and better positioned treatment systems than communities that relied primarily on enforcement. This was documented, published, and largely ignored by the political systems that controlled funding allocation. What the public health response demonstrated, in aggregate, was that the tools to significantly reduce the death toll from Grey Death existed. They were not experimental or theoretical. They were evidence-based, costed, implementable, and proven in real-world conditions. The barrier was not knowledge. It was the gap between what the evidence said and what the political system was willing to fund, legalize, and scale. And while that gap persisted, the drug supply continued evolving, generating new compounds, new mixtures, new challenges, at a pace that no public health system optimized for political palatability could match. Grey Death didn't disappear. No drug crisis in modern history has simply ended. They transform, mutate, find new vectors, and re-emerge in forms that render the previous response infrastructure partially obsolete. The specific mixture that the Georgia Bureau of Investigation identified in 2017 became less visible in forensic data over subsequent years, not because the threat it represented had been neutralized, but because the underlying chemical ecosystem that produced it kept generating new iterations. The name Grey Death faded from headlines while the conditions that created it remained entirely intact, running at full capacity, producing new compounds with the same indifference to human consequences that had characterized every previous stage of the synthetic opioid crisis. The most significant development in the years following Grey Death's peak visibility was the near-complete dominance of illicitly manufactured fentanyl in the American opioid supply. By 2021, fentanyl was present in the majority of overdose deaths across the United States. Not just opioid deaths, but drug overdose deaths broadly. It was appearing in cocaine supplies, in methamphetamine, in counterfeit benzodiazepines. The contamination had spread beyond the opioid market into the entire illicit drug supply, meaning people who had never used opioids and had no opioid tolerance were dying from fentanyl exposure when they used drugs they believed contained something else entirely. The 2021 overdose death toll exceeded 107,000, the highest ever recorded in a single year in American history. Synthetic opioids, primarily fentanyl, accounted for the majority. Xylazine arrived in the public consciousness around 2022, representing a new dimension of the problem rather than a continuation of the old one. Xylazine is a veterinary sedative, another animal drug, following the carfentanil pattern, used primarily in large animal veterinary medicine. It is not an opioid. It does not bind to opioid receptors. Naloxone has no effect on it whatsoever. When xylazine began appearing as an adulterant in fentanyl supplies, primarily in Philadelphia initially and then spreading nationally, it introduced a complication that the entire naloxone-centered public health response was structurally unable to address. An overdose involving fentanyl plus xylazine might respond partially to naloxone. The fentanyl component would be reversed, but the xylazine component would continue producing sedation and respiratory depression. First responders who administered naloxone and saw partial recovery were now managing a residual toxidrome with no available antidote. Xylazine also caused something fentanyl and carfentanil did not: severe skin wounds. Injection of xylazine or even injection of fentanyl adulterated with xylazine produced necrotic skin lesions, areas of tissue death that, without proper medical treatment, progressed to severe wounds requiring debridement or amputation. People in Philadelphia's xylazine-affected drug-using population developed wounds of a severity that emergency physicians more commonly associated with battlefield injuries. The wound care burden fell disproportionately on harm reduction organizations, which found themselves providing wound care services they had never anticipated needing to offer, with funding structures that hadn't anticipated this need either. The nitazines represented the most technically alarming development in the post-Grey Death landscape. This class of synthetic opioids had been synthesized in the 1950s by a Swiss pharmaceutical company, Ciba, as part of a search for non-addictive opioid alternatives. Like carfentanil, they had never been approved for human use and had existed primarily in the research literature for decades. Unlike the fentanyl analogues that had dominated the previous decade of synthetic opioid proliferation, nitazines were structurally entirely different from fentanyl, meaning that detection methods, scheduling frameworks, and clinical knowledge developed for the fentanyl crisis didn't transfer. They were, in effect, a second synthetic opioid crisis beginning while the first was still ongoing. Isotonitazine, the first nitazine to appear significantly in American drug samples, was detected in 2019 and 2020. Its potency was comparable to fentanyl. Its detection required specialized testing that most laboratories weren't running, and its response to naloxone was uncertain. Early clinical reports suggested that higher doses were needed, following the pattern established by carfentanil. Metonitazine, butonitazine, and flunitazine followed, each variant presenting slightly different pharmacological profiles and requiring specific identification to distinguish from the others. The forensic toxicology community, which had spent years calibrating systems to detect the fentanyl analog class, was confronted with an entirely new chemical family requiring entirely new reference standards, detection methods, and clinical protocols. Europe encountered the nitazines earlier and more severely than the United States in certain respects, partly because European heroin markets had been disrupted by COVID-19's impact on supply chains, creating demand for synthetic alternatives that nitazine suppliers moved to fill. Estonia, a small Baltic nation that had experienced Europe's worst drug-related death rates for years, driven by fentanyl, saw nitazine detections increase sharply from 2021 onward. The United Kingdom's drug early warning system flagged multiple nitazine-related deaths in 2021 and 2022. The geographic spread from east to west in Europe mirrored, with about a 5-year lag, the pattern the United States had experienced with fentanyl, a sobering preview of what global synthetic opioid proliferation looked like as it moved through different drug markets. The COVID-19 pandemic intersected with the synthetic opioid crisis in ways that amplified its lethality. Lockdowns disrupted drug supply chains, producing batch inconsistency that increased overdose risk. Social isolation eliminated the informal safety networks, using with others present, checking on friends, being found quickly after an overdose, that harm reduction relied on. treatment services contracted or shifted to telehealth formats that excluded people without stable housing or smartphones. Overdose death rates, which had been showing modest improvement in some states during 2018 and 2019 as treatment access slowly expanded, reversed sharply upward in 2020 and continued climbing through 2021. The pandemic didn't create the synthetic opioid crisis, but it removed several of the supports that had been limiting its impact. The cartel dimension of the crisis deepened considerably after China's 2019 fentanyl ban. By the early 2000s, the Sinaloa cartel and the Jalisco New Generation cartel had achieved a level of synthetic opioid production capacity that DEA analysts described as industrial scale. Fentanyl pressed into counterfeit pills, the M30 tablets designed to resemble 30 milligrams oxycodone, had become one of the primary distribution formats, moving through existing cartel channels into markets across the country. The seizure numbers were staggering in their absolute scale and humbling in their implication. In 2022 alone, the DEA seized over 379 million fentanyl pills and more than 10,000 pounds of fentanyl powder. By the DEA's own estimates, these seizures represented a fraction of the total supply. The volume moving through was incomprehensible. The human geography of the crisis shifted during this period in ways that complicated the public narrative. Early opioid crisis coverage had focused heavily on white, rural working-class communities, a framing that was partly accurate and partly a reflection of whose suffering received media attention. As synthetic opioids penetrated the cocaine and stimulant supply, overdose deaths increased sharply among Black Americans, who had historically used opioids at lower rates than white Americans, but whose drug supply was now contaminated with fentanyl regardless of what they were specifically purchasing. The racial distribution of overdose deaths began shifting in the early 2000s in ways that reflected fentanyl's total market penetration rather than any single community's drug use patterns. Indigenous communities in the western United States faced the cartel-produced fentanyl supply with healthcare infrastructure even more inadequate than what served rural white communities in Appalachia. Reservation-based healthcare systems, chronically underfunded and geographically isolated, had limited treatment capacity and severe naloxone distribution gaps. Overdose death rates in Native American communities surpassed those of every other demographic group by the early 2000s, a development that received a fraction of the media coverage devoted to the opioid crisis's earlier phase. The crisis had expanded its geography and its demography, while the public's attention had partially moved elsewhere. The fundamental paradox that Grey Death had crystallized remained unresolved, and in some respects had deepened. The pharmaceutical escalation that Paul Janssen had begun, without malice, without foresight of this outcome with genuine scientific purpose, had produced a chain of increasingly potent compounds that culminated not in better medicine, but in street drugs that required hazmat protocols. The regulatory systems designed to control that escalation had been perpetually reactive, always arriving after the damage was done. The treatment systems that could address the demand side of the crisis remained underfunded, inaccessible, and politically constrained. The communities absorbing the highest death tolls were the communities with the fewest resources to respond. And the chemistry kept moving. The same logic that had taken morphine to heroin, heroin to fentanyl, fentanyl to carfentanil, and carfentanil to Grey Death was still operating. Nitazines were already in the supply. New analogues were already in synthesis. Compounds that hadn't yet been named were already in transit through postal systems, moving toward communities that didn't yet know to test for them. The forensic toxicologists who would first identify the next Grey Death were currently processing samples from the current crisis, not yet knowing which sample would be the one that required a new reference standard, a new alert, a new protocol. grey death wasn't the endpoint of 60 years of pharmaceutical escalation. It was a checkpoint, a moment when the accumulated velocity of the crisis became briefly visible before disappearing back into the data stream. The system that produced it, the intersection of pharmaceutical innovation, market economics, regulatory inadequacy, and the desperate human need that drives demand, was still running at full speed. It had never stopped. It had simply stopped making headlines, which is not the same thing as stopping. The lesson of grey death, traced from Paul Janssen's laboratory in 1960 through the poppy fields of ancient Sumer, through the pill mills of Florida and the chemical factories of Wuhan and the cartel labs of Sinaloa, is not that science is dangerous or that chemistry is the enemy. The lesson is that systems have momentum, that solutions become problems, that every escalation produces the conditions for the next one, that the distance between a medicine and a weapon is often nothing more than context, concentration, and the particular human desperation that makes someone willing to take the risk. The grey, concrete-textured powder that a forensic analyst in Georgia held under a laboratory light in 2017 was the product of everything that had come before it, and the warning of everything still to come.